to Dr. Teresita de Guia, to our esteemed colleagues, good afternoon. It is an honor to be the speaker of the Teresita de Guia Honor Lecture. I will speak on the topic which is all too familiar to everyone. Hyperinflation in COVID-19 and stem cell therapy, another piece of the puzzle. Two important structures are presented. The two large round coronavirus and the small minute angiotensin converting enzyme receptors or ACE2 receptor on the cell wall. Viral entry into the cells is facilitated through the ACE2 receptors. The ACE2 receptors are abundantly expressed in the respiratory epithelium from the nose to the alveoli. The type 2 pneumocytes and vascular endothelial cells make up the most proportion. Take note that the angiotensin converting enzyme plays a major role in the pulmonary vascular homeostasis and pulmonary hemodynamics. Other cells where coronavirus gain entry are the cells of the GI tract, kidneys, and blood. Viral replication begins prior to the onset of the symptoms and continue around 10 days after the onset of the symptoms. The duration may be longer among patients who are immune compromised or who have serious illness. A systemic pro-inflammatory response may begin within 10 days of the onset of the symptoms and can be progressive, causing the patient to go into severe illness or cytokine storm. COVID-19 is a disease with varied severity in symptoms. COVID-19 patients are categorized under three major classifications: the mild, the moderate, and the severe. The mild symptoms comprise 80% of the infected population. Patients have minor or non-specific symptoms. They will not progress to severe disease. The moderate symptoms is estimated to be 15% of the infected population. Patients have overt pneumonia with or without overt hypoxia, localized inflammation, and will require hospitalization. The severe symptoms, about 5% of the infected population, show systemic inflammatory response syndrome, cytokine storm, acute lung injury requiring mechanical ventilation and critical care management. Viral transmission occurs in all of these classes. The inflammatory response of the host is related to the viral titer. During the initial phase of the inflammatory response, the immune cells and inflammatory cytokines are able to suppress the virus. In severe illness, the virus overwhelms the immune cells and killer cells. Cytokine response becomes erratic and dysregulated, causing the hyperimmune state, or what we allude to as cytokine storm. Severe illness and even death occurs. Hyperinflammation is manifested through inflammatory markers such as elevation of the cytokines, chemokines, growth factors, C-reactive proteins, procalcitonin, lactic dehydrogenase. The consequent hypercoagulable state in COVID-19 is reflected on the D-dimer levels, fibrinogen, fibrin degradation products, prothrombin time, activated partial thromboplastin time. A consequent cardiac dysfunction is manifested through the cardiac troponins and proBNPs. Chest pulmonary fibrosis is an expected finding in COVID-19. The potential biomarkers of fibrosis are your matrix metalloproteinases, the galectin-3, the vascular endothelial growth factors, and interleukin-6. Chest images of hyperinflammation in COVID-19 on chest X-ray and chest CT scan will show diffuse patchy areas of ground glass opacities on both lung fields. The gross picture of the lungs of patients who die of COVID-19 infection show congested, heavy lungs with pale to bluish surfaces. That's on the left side. Another with patchy pale and pink hypercapillarized surfaces with firm, friable consistency. A typical picture of a swollen lungs. The histologic picture of COVID-19 showed diffuse alveolar damage with hyaline membrane, edema, and collapsed alveoli. Alongside are areas of hyperplasia of the epithelial cells and some with fibroproliferation. Alongside areas of diffuse alveolar damage are microemboli on the small-sized pulmonary arteries. Here, a pulmonary infarction is seen on the lowest picture. Thrombosis signifies a hypercoagulable state. In this series of autopsies, 55% showed DVTs. These slides will show that other organs, aside from the pulmonary, are affected by COVID-19 infection, supporting the idea that COVID-19 is a multi-organ disease. The consistent histologic pattern in COVID-19 are your diffuse alveolar damage, pulmonary edema, injury of the alveolar and vascular endothelium, exudation of proteinaceous fluid, hyaline membrane formation, hyperplasia of pneumocytes, and fibroblastic proliferation. The basic components of ARDS are present in COVID-19, acute lung injury. In ARDS, however, we see defined stages of early exudative, late proliferative, and the fibroblastic proliferation. The COVID severe lung injury, in COVID-19 severe lung injury, we have the basic component of ARDS, plus the findings of heterogeneity in patterns of injury and repair, the findings of thrombosis in the small capillaries and large arteries, organizing pneumonia, and pulmonary fibrosis. In his observation during the early part of the pandemic, Luciano Gattinoni made a remark that COVID-19 does not lead to atypical ARDS. In COVID-19, severe lung injury, mechanical ventilator strategies may vary from patient to patient, depending on the dominant pattern of injury. The ACE2 angiotensin converting enzyme plays a major role in the pulmonary vascular homeostasis and inflammation. When COVID-19 virus binds to your ACE2 receptors, it prevents ACE2 from performing its function. The situation can lead to increased blood pressure and more inflammation. In COVID-19 infected patients, the reflex hypoxic pulmonary vasoconstriction is blocked and the homeostatic oxygen sensing system is impaired. This will illustrate the contrasting pulmonary hemodynamics in ARDS, COVID-19, and high-altitude pulmonary edema. On your right side of the screen, you have three columns. The columns for ARDS, COVID-19, and high-altitude pulmonary edema. Please focus on the center column, COVID-19. The presentation of COVID-19 hypoxemic patient is not typical of ARDS. The hypoxemia is profound with minimal dyspnea. HPV is absent, therefore BQ mismatch is severe. Hypoxemia occurs despite a relatively preserved lung compliance. This atypical pulmonary hemodynamic creates a situation where there is a discord between severity of the hypoxemia and relatively mild respiratory discomfort. This is a phenomenon alluded to as the silent or happy hypoxemia in COVID patients. Therapy for COVID-19. The only therapeutics for which there is consistent evidence of efficacy are the antiviral therapy remdesivir and the immunomodulator dexamethasone. They have become the standard of care treatment. There are other antivirals on trial or on an emergency use authorization. You have your favipiravir, lopinavir, ritonavir, unifinavir, casinostat. For addressing the hyperinflammation syndrome, there are several host-directed therapies. No? And the critically ill and the elderly would require more than just the standard of care treatment. The cytokine storm is illustrated here. And this is an illustration of the pathways from the triggers of the cytokines, inflammatory cells, and signaling molecules towards a cytokine storm and even death. The host-directed therapies targets these cytokines and signaling pathways. Another or the latest host-directed therapy is your mesenchymal stromal cells, or what is called your MSCs. No? MSCs are cell-based therapy under evaluation for a broad clinical application in regenerative medicine for their immunomodulatory and regenerative medicine properties. It is hypothesized that MSCs could reduce the acute lung injury minimize organ damage by dampening excess inflammation of the cytokine storm. It was in 2015 that Michael Mathey and his group from the University of California in San Francisco, USA, who introduced stem cell therapy for the treatment of ARDS. In 2019, he published his phase 2A safety trial on the START study, stem cell for ARDS trial, funded by the National Heart and Lung and Blood Institute. This trial passed the safety criteria for patients with moderate to severe ARDS. Your mesenchymal stem cells can be sourced from the bone marrow, umbilical cord, adipose tissue, dental pulp. They are cultured and processed. They can be delivered intravenously or through the airway and delivered to the lungs. Once delivered, the MSCs are expected to calm the storm. They are expected to protect the alveolar epithelial cells, inhibit neutrophil activation, regulate T cells and dendritic cells, suppresses fibrosis, facilitate repair of the alveolar capillary damage. To date, several pharmacotherapeutic agents team up in the management of COVID-19. Stem cell treatment is still in its early investigational stage. Hopefully, it can be a piece of the puzzle in the cure of this hyper-inflammatory disorder. Thank you.
Thank you, Dr. Tady, for the very informative lecture. This is truly very timely and relevant to our current situation, and I'm sure that everybody learned a lot from this. I would like to proceed by awarding the certificate of recognition to our speaker, Dr. Cecil Z. Tady, signed by our PFLHRD President, Dr. Cesar Antonio Ligo, the Chief of the Division of Pulmonary and Critical Care Medicine, Dr. Eileen V. Guzman Banzon, and the overall chair of the 12th Biennial Symposium, Dr. Bernice Ong de la Cruz. To give a response and inspirational message to everyone, let us give a warm applause to Dr. Teresita S. de Guia.
Fellow members of the Philippine Foundation for Lung Health Research and Development, participant of this biennial symposium, friends. Despite our limitation of not being able to interact face-to-face, our learning process actually continues. Since the time we started our training program in the 70s, there was a fast pace of information in pulmonary diseases. And this fast pace, we have learned the various inflammations, as in bronchial asthma, which is different from the inflammation in COPD. Then later, we actually learned the intensive inflammation of ARDS. And today, we hear from our speaker, the honor lecturer, that there is a hyperinflation that is now occurring in patients who have COVID, which we refer to as cytokine storm. Indeed, we continue to witness this escalation in lung reactions to various insults, showing that the lung is indeed a very dynamic organ. It is also satisfying to note that all this evolution, and our trainees should take note that we will continue to evolve and adapt to benefit our patient care. I would like to thank the organizing committee who had developed this particular symposium despite the really challenges that they have met. And then I would like also to give acknowledgement, more especially to our pharmaceutical friends in the industry, because of their continued and unwavering support and cooperation to make this biennial symposium possible. So I wish us all a successful conference.
Thank you, Dr. De Guia, for your insights and inspiring words. For our next session, I would like to introduce to you our two moderators. For the adult track, Dr. Irma Melissa M. Abara-Barreros, and for the pediatric track, Dr. Arnold Nicolas Lim.